Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And you know what? It is October, and in the world of oncology, that means breast cancer. Our guest tonight is Dr. Tara Graf, medical oncologist with Mission Cancer and Blood. And our topic is going to be everything you want to know about breast cancer. Thank you all for being on time, but we're not ready to start quite yet. Dr. Graf is just finishing up in clinic, and she's just a few minutes away. So for those of you who are watching live stream, we wanted to come on air right away so that you'd know that we're here, and we're going to get started momentarily. For those of you who are watching this on demand, you won't see this yet right now because we're going to cut this out. But we can't wait to have our conversation with Dr. Graf. She's in the building and will be with me shortly. So we're going to pause a little bit here. We're going to stay live, but rather than me just chatting away, we'll just pause for a bit. And my guest, Dr. Tara Graf, will be with us in just a minute. So welcome, everyone. We're getting ready to get started. Here's our guest, Dr. Tara Graf. Tara, hey, welcome. I know you were in Centerville.
Centerville.
Thank you so
I had to go to the
much.
bathroom.
Thank you so much. So,
Sorry.
So Dr. Tara Graf, medical oncologist, Mission
everybody.
Cancer and
Yes.
Blood,
Thank
and
you for having me.
really one of the experts in breast cancer. And as you know, it's October.
It is October.
Oh my
yes.
gosh, I forgot to wear pink today.
You know, I have to say it's been pretty cool. I've been on many flights in the last couple of weeks, and all of the staff, like the flight attendants, are all wearing pink.
Yeah.
I don't know if you've noticed this. It's a
It
pretty
is.
cool thing.
It's really become a national phenomenon.
Mhm.
Actually, I was talking with a patient just last night who is a bit troubled by it because says it's sort of like a triggering phenomenon that she's a cancer survivor, but is only a couple of years out and still being reminded that she's a breast cancer
Yeah.
survivor causes her to think about fear of recurrence.
It's like post-traumatic stress.
Yes.
I mean,
Yes.
It's a reality. I think it's interesting how different people are, though, right? Because a lot of our patients find comfort in, the support groups, the walks, the organizations, private groups, Facebook groups, and other patients. It's kind of like out of sight, out of mind.
Every patient's a little different.
They are.
Tell you what, Dr. Graf, why don't you scoot a little closer to me
yeah.
here?
Sorry about that. Yeah.
And before we talk about breast cancer, we want to know a little bit about you. So what state did you grow up in?
Illinois.
So high school in Illinois.
Yeah, Chicago.
Okay. Oh, and what was your claim to fame in high school?
My claim to fame in high school.
I know you're an athlete. Were you an athlete in high school? Were you?
I was an athlete. I was actually a pilot.
You are a pilot?
Yeah.
How old were you when you started taking flight?
15.
15.
Yeah.
And what prompted that?
I come from a long line of military pilots, no doctors. I am the only doctor in my family. Huge.
So at age 15,
yeah.
if you had to bet, would you have bet you would be a pilot or a doctor?
Pilot, 100%.
Okay.
I never would I have thought that I'd be sitting here.
Okay. So when you graduate from high school, where did you go?
The University of North Dakota, because it had the #1 aviation college in the
Really?
country at
So
the
you
time.
went to college for
Yeah.
aviation,
Mm-hmm.
University of North
Yeah.
Dakota. So when did it switch from pilot to doctor?
So interesting. I had a professor at North Dakota who gave us this wonderful, uplifting lecture about how we were going to be eating beans and weenies until we were 35 years old, because that's how long it would take us to build up hours to
You
become
mean pilots?
to
So
be a
that
pilot.
pilots is
Yep, to be a pilot.
hand to mouth sort of job. You're
Exactly.
never going to make much money. And
Exactly. It's got a uphill climb. And so I actually believed him, and he's not wrong. And so I'm like, wait, this is crazy. Like, I love to fly for fun. This is a passion and excitement. Maybe I don't want to do this for a career. So I actually finished out the semester, moved back home to Illinois. And that is when I decided that I was going to switch from an aviation major. What do you do with that? To biology. And so I got into school again very quickly. And then I thought about doing pharmacy. I really had no idea what I was going to do. And then I'm like, I can do this medicine thing.
yeah.
And so here I am.
So undergrad degree at what institution?
Undergrad at at Elmhurst College.
Okay.
And then what people don't really realize about me is that I'm a basic science nerd. And so I actually went and got my master's degree in immunology from Loyola. And that's what I did. And then I did cancer research. So my passion prior to coming here 9 years ago was lymphoma and bone marrow transplant. And so now here in Des Moines, that is sort of my focus, is breast and lymphoma. So all my clinical trials and research are really around
Loyola
that.
Chicago for some research, and then medical school
in Florida.
And then residency in
Wisconsin.
internal medicine, and then fellowship
Wisconsin.
in Wisconsin.
And then that's where I thought I was going to be the rest of my life. And then here we are.
Right. And you also have, I think, some other personal connection with flying, right?
My husband.
Yeah. So he's in an aviation job.
Well, he was. Yeah. You probably, yeah. So
when we first met, didn't he, like, assistant manager for the
COO
for the
Des
Moines airport?
Yeah, because that's how I met you. I wasn't even here yet. I wasn't planning on moving. I thought we were going to commute back and forth from Des Moines to Milwaukee.
So he's no longer at the airport?
No, he did something very, very selfless that I not many men can do, but he decided 4 years ago that we had a village raising our precious little Izzy, who's now 8.
Your daughter, Isabel, Izzy.
And he said, you know what? He's like, you're never going to slow down. You are you. He's like, I think it's time I resign and I will run the show.
So he is.
He's at home. Yeah. And he's self-employed. He does have a job, but he is able to work from home.
And he's also a pilot.
And he is also a pilot. Yep.
Yeah. Okay.
And he will typically fly me to Centerville, but of all days, I had to drive.
You had to drive. Well, thank you for being here. So you 1 day a week, you're in Centerville, a medium-sized city in southern Iowa that really is a hub for medical care for the lower tier of Iowa and the upper tier of Missouri. Really.
Yeah, it's a very, very large catch area. And out of all of our outreach clinics, as you know, we have 22 different satellite clinics at Mission Services. It's one of our larger and busier clinics because really, between Dr. Sandry and myself, there's 2 of us there, quite often.
And so give us a sense, like, how many patients would you say you saw
30
today? 30 patients today.
Yeah, and that's typical there were times I was going and I was seeing 45 patients at a time. And
oh my gosh.
While I can do that with the help of a nurse practitioner, it's not safe for chemotherapy. You can't have chemo nurses treating that many patients. So there's a safety issue. So then we opted to go once a week.
Okay.
So,
well, let's focus a bit on breast cancer.
Yes.
So, breast cancer is the #1 cancer in terms of incidence for women.
Sure is, yeah.
And #2 in terms of death, only exceeded by lung cancer. And breast cancer has changed significantly in terms of the treatment of breast cancer.
Absolutely.
Just maybe start off by describing a bit about the various ways in which we treat breast cancer, and then we'll get into some specifics. But in general, how would you categorize breast cancer and breast cancer treatment?
So, breast cancer, as I tell patients when I meet them for the first time, is not a one size fits all disease. It is not. And I mean, in this day and age, we can't really say that about a lot of cancers, but it's not comparable to lung and colon, where it's vastly different based on different markers that are involved in breast
Mhm.
cancer. I always describe it as flavors to my patients. I say there's multiple flavors, and depending on what combination you have is really how we approach those patients. For a lot of people, even our advanced breast cancer patients, that may simply be some pills, nothing to do with chemotherapy,
Mhm.
just manipulating for patients who have hormone positive breast cancer per se, just manipulating the hormone receptors. And so, I have many patients with stage 4 disease who've been living for 5, even 10 years just on an
Yes.
anti-estrogen pill. Sometimes we have to add in a little extra help with another shot or something, but they're not on any chemotherapy, which is
Yeah.
amazing.
Well, let's start with this hormone or estrogen.
Yeah.
So clearly, one of the distinguishing features of breast cancer, obviously, it's mostly seen in women, but not
Not
exclusively.
exclusively.
There's a small number of men, and if a man has breast cancer, there's a high likelihood that that man might have a genetic mutation.
Mhm.
But let's talk about women and
Yes.
breast cancer. So for most women, breast cancer is affected, modulated, mediated by this milieu of estrogens,
Mhm.
progesterones. I mean, even going back to embryology and the development of human
Mhm.
beings, breasts develop
Because of our
because of the
hormones.
hormones. And
Right.
once puberty kicks in and the ovaries start making
Right.
more estrogen, that's the signal to begin to develop breast
Right. So
tissue.
something that's so inherent to a female's body and what we need can also be a detriment, right? Because
Mhm.
we know that there are some people that are more estrogen dominant than others. What we don't think about is our adipose tissue. I mean, in this country, obesity is a real thing, right? And so our adipose tissue, makes and stores estrogen. Alcohol increases the risk for hormone positive breast cancer. So there's so many
Mhm.
different modifiable risks that we can think about as a population for
Right.
hormone positive breast
And
cancer.
we think of the ovaries as the number one maker of estrogen, but as you pointed out,
Mhm.
other organs in the
Adrenal
body,
glands.
including fat cells,
Mhm.
adrenal, liver,
Yeah,
make some estrogen.
right.
When we look at the ovary, what does the role of how soon a woman starts having menstrual periods, how long they have menstrual periods, how many times they're pregnant, how does that affect one's risk of developing or not developing breast cancer?
So the longer a woman is exposed to estrogen itself, is an increased risk for breast cancer. So if a girl starts her period at age 8, never has a child, and doesn't go through menopause until 57, that's a lot of years of being exposed to estrogen. When we are pregnant, obviously those hormones shift, right? Estrogen's going down, progesterone's going up, so you're not having the continuous exposure. So a
So that's
woman
why having a pregnancy earlier in life and having many pregnancies during the time you're pregnant, you're
Right.
actually reducing your
You
exposure
are,
to
yes.
estrogen.
I mean, in theory, when I give the residents this talk, most of us who are physicians, not everybody, I had my daughter when I was 30, almost 38 years old. So that's a long time of, estrogen exposure before having a child. And I think, when women are in a professional role, which is very common now, they're not having families in their 20s, and they're not having 6 children.
Mhm.
So that idea is like, well, God, you're right behind the 8 ball,
Right. So great
So
grandma who had her first child at age 17 and her last
right,
child at 42, and there were 12 of them,
right,
her risk of
great
breast
job.
cancer
Much
was
lower,
much lower.
right?
Yeah.
So it's amazing though how we develop as a society. It actually has a risk on
Yeah.
our overall well being.
And it goes almost without saying, but we'll say it, that then after menopause, taking estrogen after
Right.
menopause definitely helps with the symptoms of menopause, but clearly
Right.
increases the risk of breast cancer.
And, for such a long time, about 18 years ago, every woman got a prescription for Premarin or Prempro, or, it was just a common thing. Oh, you're going through menopause. Here's your pack. Obviously we see that less and less, but we still see it. I mean, I had a consult today in Centerville, in fact, and the woman came hormone positive breast cancer stage 1, she's going to be great. But then her sister was sitting there talking about how she takes hormones. They were laughing about it. That one's going to go on an anti-hormone.
Well,
And
and there's doc in the shops and malls where you can
Oh,
go
yeah.
get a testosterone shot, or you can get your
Right.
estrogen. And so it's become very accessible too.
It has. And the other concern too is that, estrogens or estrogen-like compounds are now being hidden, in our makeup, in our foods.
Really?
Yes. I mean, so it's kind of hard that you could do everything right and you have no idea, what's going on that you're putting, in your body. Now, obviously, there's a lot of different ways to look at that, but the more education we have, the better.
So sticking with this theme of the effect of hormones on breast cancer, what about breastfeeding? Is that protective or not? And what about the use of birth control? Does that have any impact on increasing or lowering the risk of developing breast cancer?
So breastfeeding, is felt to be a modifiable risk factor, which is just hard and puts a lot of stress on a woman because not everybody can breastfeed, right? Or chooses to breastfeed. So that is felt to be, again, it's that shift in hormones, right? Your estrogen's not super high while you're breastfeeding. So it is felt to be, a risk reducer, if you will.
Okay.
Now, in terms of birth control, so our hormone replacement therapy has been linked to increased risk for breast cancer. There's not really a good consensus yet on birth control or even IVF, right? Because these women who are going through,
in vitro
fertilization, right? Fortunately, a lot of the birth control pills that are on the market now, back in the 1970s, they were highly estrogen dominant. They were, that was the main component of a birth control pill, which is why women were always sick and nauseous when they were on birth control pills. Now there's this, a lot of the times the progesterone is actually a little bit higher than the estrogen component. So, there's not a good consensus on that.
Okay.
But I mean, I would consider it a risk. I mean, if you had a female that had a, family history of breast cancer, I think it's something to keep in mind. Why are you going to give the body hormones when there's this risk?
So we've been talking about the effect of various hormones, estrogen, progesterone, how various lifestyle and just characteristics might increase or lower the risk of breast cancer. What are other factors? We'll talk about genetics and then other modifiable risk factors that we know increase a woman's chance of getting breast cancer. First, let's start with genetics. What do we know about genetic mutations that we might have gotten from our mom or dad that increase the risk of breast cancer?
So, historically, when we think about breast cancer, we've thrown around BRCA, right? BRCA1, BRCA2, but we also know there are other mutations like CHEK or PALB2. So it's not just, oh, I don't have BRCA, I was tested for that. Because that's how it was for a lot of women. They were just tested for BRCA and that was it. But we know that there are other mutations that we need to take just as seriously as the BRCA genes. But the interesting thing is that less than 10% of our breast cancers are actually inherited.
Right.
Which
so we
means
talk a lot about the BRCA, but
Right.
really only about 10% of
Right.
women's breast cancer are related to a gene they inherited.
Mhm.
So besides the whole estrogen milieu, what are other modifiable risk factors for breast cancer?
BMI. We know that an increased BMI is a risk for breast cancer.
So the
For
body mass index.
the body mass index, because again, the more adipose tissue you have, it's like a big, repository for estrogen. And I mentioned alcohol. So alcohol actually, so a woman who there's a study that's even done in preteens, if you will, that preteens that drink 1 to 4 alcoholic drinks per week, which I hope 12-year-olds aren't like drinking that much, there's actually an increased risk for development of hormone positive. So the alcohol link is to hormone positive breast cancer.
In the future.
In the
Obviously
future.
not as a
In the
teen, not in
future.
the 20s, but
In the
if you
future.
look at their okay.
And it's not, I just drink
Wow.
beer. So it's beer, wine,
Any
it
alcohol.
doesn't matter. Yeah.
Okay.
And then if a woman has had breast cancer and continues to consume alcohol, which I mean, I don't know, I'd want a celebratory drink if I went through chemo, but if you have, about, I think the average is 3 drinks per week, you can increase your risk for recurrence of hormone positive breast cancer. So we're talking specifically about hormone positive. Yeah.
So we talked about body mass index,
Mhm.
being overweight. We talked about alcohol.
Yep.
Physical activity also is linked.
Mhm.
Sometimes it's hard to sort out the difference between diet, physical activity, and body fat. So we sometimes call that the triad
Right.
of inactivity, too many
Right.
calories,
Right. It's the
and
adiposity.
obesity.
It's really the adipose tissue that is
Okay.
the big. The other thing is too is that if we're overweight, there's an upregulation of insulin-like growth hormone, right? And so you stimulate that, you're stimulating more insulin, you're stimulating inflammation, and it's that overall inflammation in the body
Mhm.
that really can lead to cancer cell growth. People always say, oh, can stress cause cancer? I mean, I don't think stress directly causes cancer, but it's kind of the inadvertent cycle of stress and cortisol and inflammation and weight gain and whatever other habits may come from that I think is sort of a vicious cycle.
So we often refer now to personalized medicine. So when I first heard that phrase like 10 years ago, I thought they were talking about like TLC, getting tender, loving care while you're getting this
Yeah.
personalized cancer. But personalized oncology really is well, you define what is it when we talk about personalized.
Well, again, I use
oncology.
the example of it's not one size fits all, right? Like your plan is not my plan. I'll tell my patients when they come into a room, because we all hear, I always laugh on Monday mornings. I'm like, don't listen to the ladies at church on Sundays. They're going to tell you exactly about their cancer, how it should be done, and how it was done. That's not true. I always tell my patients, I can line 5 women up in a room, and chances are everyone's breast cancer is going to be different, and everyone's treatment might differ, and that's personalized. You are really looking at the individual patient. You may be looking at comorbidities, you may be looking at other factors, not just disease characteristics, when you tailor the treatment to them.
Right.
It's not just, oh, what's in my hat
So
today.
there's the breast cancer characteristics, and then there's the patient's characteristics.
Right.
Let's talk some specifically about the breast cancer characteristics. And just to throw out there, that personalized is now sometimes referred to as precision oncology. So again, it's what can we know about this patient's cancer cells that might direct the therapy? So we talked about estrogen. So one of the key factors is this, after you do a biopsy and you look at the pathologist looks at these cancer cells, one of the things they test for that's critical is, do the cancer cells have estrogen receptors on the cancer cells? So talk a bit about estrogen receptors, and then obviously progesterone receptors as well.
Yeah, so I'll draw a circle sometimes, and I'll say, okay, you have these homing beacons on the cell, right? One might be estrogen, one might be progesterone. We're not going down the path of HER2 yet, but there's another protein essential for some tumor cell growth called HER2. And so those markers really are dictating the behavior of the breast cancer cell, whether they have those receptors or not. As you and I know, which not everybody does, is that not every breast cancer has all 3. Some have none of them, and some have a combination of the 3. So it really is, like I said, it's multiple flavors.
Yeah.
And so those estrogen and progesterone markers are more, they have an extracellular, and then so part of it outside the cell, part of it inside the cell. And so the estrogen, you think of it as a floating ball in space, will bind to that little homing beacon. And then I said the magic happens, then it sends a stimulus through the cell, and then you have the growth or the it's the catalyst that kind of promotes
Right,
cell growth of
right.
the cancer cell.
So one of the ways I think of it, and I'm just I kind of made this up, so I want
Don't we
your
all?
reaction. Yeah, so a normal breast cell
Mhm.
has estrogen receptors and progesterone
Right.
receptors on it, and the more that the cancer cell is like a regular breast cell, the more well behaved it tends to be.
Right.
And so a normal breast cell has estrogen receptors, a normal breast cell has progesterone receptors. And if if a woman's breast cancer cells have those, it tends to be a more indolent, more slow growing. So
Right.
those hormone receptor positive cancer cells tend to be more well behaved.
Yes, in most cases,
cases.
yes. There's always a few, um, you know, we say what wolves in sheep's clothing,
Yeah,
right? We
yeah.
know that there are some of our patients that majority of times that is 100% true, but we do know once in a while, sometimes that progesterone percentage, or really the percentage too, you might not have
Right. We
100%
just to
the
call it, you used to just say positive or negative, and
right,
now
it's really
we're
not
recording the percentage.
right.
So there's probably a big difference between a cancer, a tumor that has 95% positive estrogen receptor versus a tumor that's 5% positive.
Exactly. Yeah.
Let's talk about that third one
Mhm.
that we often will get in a pathology report, and that's HER2, or we
Mhm.
sometimes say HER2 new.
Yep.
What is HER2 new?
So I always think of that, we talk about the receptor. So that's not really a receptor. That's actually a growth protein, or
And is it on the surface of the cancer
well,
cell? Or?
it's both. There's a
Okay.
and what the magic happens inside the cell when we call it dimerization, the intracellular. So inside the cell, when those, there's an outside part, but then it's when the inside pieces come together that then send this, basically domino effect down into the nucleus of the cell where cells grow. We're going back to cell biology 101 here, but
Mhm.
the magic of that happens internally with like I said, those parts of those proteins coming together.
So a woman having a HER2 positivity is a little bit of a double-edged sword, right?
Yes.
So it's a little bit more of an aggressive cancer. Let's say you're estrogen receptor positive and progesterone receptor positive, but the most favorable combination would be estrogen receptor positive, progesterone receptor positive, HER2 negative.
Right.
But if you do have HER2 positivity, one of the positive things is that there's actually a targeted drug or
Right.
targeted drugs
Yes.
that are made specifically
Right.
to kill HER2 positive cells.
So, and that is very true. So I will usually kind of map out a treatment plan for the patients, and I'm like, we're going to have targets. We're not just going to give you chemotherapy. We might have to give some chemo in there, but we are going to target this. So we're not just going to kill random cells. We're going to go right after the breast cancer cells with that cocktail, if you will. So we use different drugs. Perjeta is one of them. Herceptin is one of them. In some cases, we'll use a drug called Kadcyla, and we're not doing a drug show, but those are very, very important and have really changed really just changed the whole treatment paradigm of how we approach these patients. Once they get their initial therapy, then they will complete a year of maintenance therapy with those targeted agents. And so it's a real big deal because you're not just giving them random chemotherapy. You're actually really honing in on, the cell that's causing the issue.
Yep. Precision.
There you go. Yep.
And then let's spend a little time talking about triple negative. What does that phrase triple negative mean, and what's the implications?
So triple negative breast cancer is obviously our most aggressive breast cancer. And being the basic scientist and immunologist that I am, I remember being a resident and doing a breast cancer clinic, and the gentleman, the physician I was with, actually is very similar to me. He was he split his, in an academic institution, split his time between lymphoma clinic and breast clinic. And so he loved them both. He did them both. And he said, he's like, I really believe that our immune system, that the immune microenvironment of a triple negative breast cancer cell, like that's where the money's at. That's where we need to figure out how to manipulate it. Because there's different immune drivers in a triple negative breast cancer patient.
Define though, what are the 3 things that are negative in triple negative?
Okay, so we talked about the estrogen receptor, the progesterone receptor, and that HER2, right?
So if all 3 of
they're all
those are negative,
I always
that's
say it's a naked cell.
that's
That's how I describe it. It's a naked cell. And so, sticking with that hypothesis about the immune system, fast forward now many years later, that is a lot of where our attention has gone to with a lot of different agents. Usually, historically, for triple negative breast cancer patients, it's really just been chemo, and more chemo. And it's sort of, there are many patients that are diagnosed with triple negative breast cancer that do very well, but we know that it has the highest risk of recurrence within 5 years, and especially within those first 2 to 3 years. So when you talk about a triple negative breast cancer patient, that 5-year mark for them is a very big deal. Whereas hormone positive breast cancer patients, I'm not bringing in the HER2, I'm just bringing in the traditional ER/PR positive patient. We know that while it's very slow growing and very well behaved, we can see it recur
20,
30
30
years later.
Yeah.
So you don't have that, I made it 5 years, it's never coming back, right? So for a triple negative breast cancer patient, that 5-year anniversary is a big anniversary. Now talking about treatment specifically, for upfront treatment, we still use conventional chemotherapy, but in some cases now we pair it with immunotherapy. There are regimens that use Keytruda, which is an immunotherapy medication we use across many different cancer types. So that's one example.
Right. And so that works not by the drug killing cancer cells, but by the drug revving up the body's immune
your
system
own immune system
to kill the cancer cells.
Exactly. And there's other, targeted agents for triple negative breast cancer, like Trodelvy, which is another drug, an antibody drug conjugate. So it's an immunotherapy, if you will, tagged to a chemotherapy kind of carrier. So we're really making strides with triple negative breast cancer, looking at ways to enhance or sort of rev up or alter that immune microenvironment. So,
and let's talk a bit more about treatment, because that's changed a lot. And one of the biggest changes has been sequencing of treatment. So I would say historically, let's say 40 years ago, surgeries first. I mean, unless you have metastatic disease, and we'll save time to talk about stage 4 metastatic. But if you didn't, it was like surgeries first, then follow it with systemic treatment and radiation, and sometimes the order would switch.
Right
now, there's many more patients that are getting the systemic treatment or the chemo or hormone or anti-HER treatment up front, following by surgery. Talk a little bit about how that shifted and why there was a shift to bringing the medicine to treat breast cancer up before the surgery.
So, a couple different reasons behind that. Overall, if you have a woman that has a aggressive cancer or even just a large tumor with, say, lymph node involvement, giving treatment up front and shrinking the cancer, if you will, one, you're going after the tumor right away. You're not waiting. And number two, by shrinking it up, you're really setting the patient up, hopefully, for better surgical options. You might have had a woman that the only option would have been to do a mastectomy. And now by doing neoadjuvant or upfront chemotherapy, we can shrink that tumor, and now they have options. Maybe it's not just, mastectomy, but you can do a lumpectomy and radiation. For triple negative breast cancer, it's actually a prognostic marker. So if you have a patient with a naked cell, right, triple negative breast cancer, and they have a complete response, which means when they have their chemo and when they go for surgery following chemo, if they have no residual tumor remaining, that's a very, very good prognostic sign that their cancer will hopefully not recur.
Right.
So it actually has not only treatment benefit, but there's actually a prognostic benefit. And I always use the example too that what if you go for surgery first and there's complications? What if, there's a wound, the wound opens up, or what if they don't heal, or if they're...
And even if there aren't complications, there's at least a month delay before you get started.
Exactly.
And you said one thing, and I'm just going to amplify it, that that one of the reasons that chemotherapy has improved the cure rate is that even when we do all the scans and we don't see any cancer cells anywhere other than in the breast or the lymph nodes, the reason most women who do die of breast cancer is that even before you do the surgery, there are some cancer cells hiding elsewhere in the body
The
you
crumbs.
just don't know about.
Mhm.
And so by coming with chemo up front,
Mhm.
you're actually not just treating the cancer you know
Right.
about, but you're potentially
Mhm.
eradicating cells elsewhere in the body
Right.
that may turn out to be the most important cells
Right.
in terms of whether the patient ultimately survives their
Right.
breast cancer. So you're treating
The
all
whole
the cancer.
everything. Because that's the thing too, is that when you go to surgery first and you have to heal, even if it's just the minimum time of 4 weeks, you're still letting those microscopic crumbs that the eye can't see and the
Mhm.
scans can't see flourish.
I've also heard that perhaps the general anesthesia and the body shock of the surgery has an immunosuppressive effect,
Yeah, it
and
can.
that just undergoing surgery before you get started with any of the treatment might suppress the immune system a bit, so that those crumbs, as you would say, or those cancer cells that might be hiding unbeknownst to us, might have a chance to flourish a
Right.
little bit
Exactly.
during that time.
Right. So yeah, it's interesting, how I think we've gotten a lot better. I really do think, and even there's some patients too that aren't necessarily healthy or strong enough for strong enough for surgery up front. If a patient has, multiple cardiac or heart issues or a diabetic, taking them to surgery could be, there could be a lot of implications from doing that. So in some cases, we'll use not chemo, but our anti-estrogen pills we
Mhm.
spoke about in those patients who are hormone positive or estrogen positive. And we can actually, I say buy some time, but we can almost freeze the disease in time and allow them to work with their primary care doctors to bring down their, blood sugars and to, be a better surgical candidate. So, there's different reasons for doing treatment up front. And I feel just like in the last couple years, we've used more of the anti-estrogen pills
Mhm.
to delay surgery for different reasons.
One thing that I've seen, and let's talk about, is that those women who have estrogen receptor positive, there's a difference between treatment of a premenopausal woman.
Mhm.
So let's say a woman before she's had menopause gets breast cancer that's estrogen receptor positive, versus a woman after menopause who gets estrogen receptor
Mhm.
positive. Now I'm seeing treatment for those premenopausal, not only of using an anti-estrogen, but of trying to shut off the ovaries.
Yes.
And that's a relatively new thing.
So the data behind double blockade has actually been out for more than a decade, but I don't feel we've used it as much probably the last 5 to 7 years. Even to the point that, conventionally for a premenopausal woman, we would use tamoxifen. That was the first drug developed actually in Chicago, Northwestern,
Okay.
for women who
Talk about one of the fundamental targeted therapies, right?
So so basically, and it didn't block estrogen, it was a decoy. So I talked about those receptors right on the cell. I always say it's like putting chewing gum in the gas tank, probably a bad analogy, but it would bind to the estrogen receptor so that the estrogen in the body in a female premenopausal body could not bind. So it was a decoy. You couldn't put the hose in the hole. Okay. So that is different than the drugs that we use in the postmenopausal population that actually block the formation of estrogen. If you were to give a premenopausal female one of the postmenopausal drugs, the theory is that you could actually flare breast cancer. Because by doing that, you're going to tell the young female's body that they don't have estrogen. So it's going to go to the pituitary and say, you better start releasing different hormones.
To the ovaries.
Go knocking on the damn door and it better release more estrogen, right? So what we would do in those cases is you'd have to do a chemical menopause. So you would use different agents in forms of shots. One commonly used drug is called Lupron, which we also use in prostate cancer. So it's just a hormone blocking. It's just shutting the signal from the brain to the ovaries or the testes off. Okay. And so by shutting off that signal, if you were to give a premenopausal woman that shot and then one of the postmenopausal pills, it actually is very effective. There's actually data suggesting there's actually even, a few percentage points of benefit, better efficacy than
Gotcha.
just using tamoxifen alone. But even with tamoxifen, so going back to a pure premenopausal patient, even using tamoxifen, if you have women that are 45 years of age or less, and we'll be honest, my youngest breast cancer patient was 21. That's young. So it's been thought that using tamoxifen alone may not be enough. And so if you do the double blockade and you shut the signal off and give the tamoxifen, you're wiping out that catalyst, the estrogen, if you will. So,
and then what's the effect on the physiology of the body of a premenopausal woman when you do the double blockade?
So they'll stop menstruating, which is really, depending on who you ask, is really the goal. I mean, you don't, you almost want them to go into a chemical menopause. But now when you're talking about a woman who's 42 and, very well done having children, that's okay. Because if you were to stop all those things, their system may or may not wake up. But if you're talking about a 21-year-old that you're blocking, who's never had a family or even thought about having a family yet, you may be taking their chances.
You might be affecting fertility.
You might be, yeah. And I have at least 4 or 5 patients that I can think about right now that have gone on to have
children
with no issue.
Yep.
Okay.
Yep.
But that is a consideration that you need to be able to discuss that with them, that could happen.
Okay. We are going to open up to questions, so I want to
Yeah.
save enough time. But let's touch a bit about stage 4 breast cancer. Maybe define for us, what does stage 4 mean? And even philosophically, how does the treatment of stage 4 breast cancer differ so much from the treatment of stage 1, 2, or 3?
That's a really good question. And I think the way that we describe stage 4 breast cancer or stage 4 any cancer really needs to be done in a very diplomatic way and really explained to a patient. So stage 4 breast cancer is when women can have stage 2 or stage 3 breast cancer where it's in the breast and in lymph nodes. So just going to lymph nodes for a breast cancer patient is not considered stage 4, which is different in some cases from other cancers. But a stage 4 breast cancer patient would mean that it is advanced beyond the breast and the nearest draining lymph node. So that could look like being in the bone or being in the liver or being in the brain or being in the lung tissue. So you've left your playpen, you've left your fenced off zone, and you've jumped ship. And you've
And
left.
it usually means it's gotten there through the bloodstream.
Yes, typically.
Yeah.
I mean, there is some lymphatic drainage.
Just through the lymphatics,
right? But the blood,
usually
yeah,
it's gotten there by circulating through the blood.
Right. So, for a stage 4 breast cancer patient, and I'm going to use the hormone positive patient as an example. As I mentioned, when a patient is stage 4 with hormone positive breast cancer, we don't even muddle the words chemotherapy in most cases. We really don't. We're like, okay, well, let's look at our anti-estrogen options. What have you seen? Have you been off therapy? What can we put you back on? Sometimes we will manipulate the cell, the cancer cell, if you will, where we'll block the estrogen, and then we'll put them on another drug that will block it'll block their one of the growth proteins in there. I'm talking about Ibrance. So you'll hit the cell from 2 different areas, but you can live a very normal life with hormone positive stage 4 breast cancer.
Good quality of life.
Quality of life. I always tell them
for over a decade.
Oh yeah. And I always tell them, this is a chronic disease. Think of this like blood pressure or hypertension, think of this like diabetes. People who have those, medical problems, they take pills every single day. So now this is one more chronic medical problem that you're going to live with, but you're going to live with it. And I think that's key.
Right. Living with cancer. One of the ways philosophically I look at, like, if somebody has, let's just say, a stage 3, we might say, buckle your seatbelt. We are going to throw everything in the kitchen sink at this, but you're only going to have to take it for 6 months, and then hopefully you're cured.
Right.
But when you're dealing with stage 4, it's like there's no, well, we're just going to treat for 6 months and we're hopefully done and you're
Right.
cured. So you have to come up with a treatment that someone can tolerate, not just for 6 months,
Right.
but
Quality of life is
indefinitely,
important
because
too. Yeah.
quality of life is huge.
So I'll always tell patients, my job is to keep you. Now, the stage 4 hormone positive breast cancer patient, in most cases, are going to do very well. But depending on what it looks like or what their exact type of breast cancer is, I'll say, my job is to keep you around as long as possible, but feeling as good as possible, because quality of life is, living 5 years, but being miserable every day of those 5 years, there's something to be said about that. Now,
Yeah.
everyone's different. We know
Yeah.
there's some patients that would be like, bring it on. And others like,
Yes.
see, I'm going to Hawaii. I'll see you later.
Yeah.
Right. So, but it is a
And
very,
it's a philosophical
is.
discussion.
It really is. And
Yeah.
every patient's different.
Would you
Every patient's
rather
different.
live 7 years with super good quality of life, or 10 years of misery? And not everybody has the right answer.
No.
And usually it's not defined that clearly,
No,
because you
it's
don't
not
know.
that easy.
Let's open it up to questions, because I'm sure we have lots of questions. So we've got a live studio audience. We'll start with the live studio audience. But if you're watching us live streaming right now, please put your questions into the comment section. All right, Poon.
Stage 3. What exactly? Of course, it's got into the lymph nodes. What else makes it a cancer stage 3?
So how would you
breast?
distinguish a stage 2 from a stage 3?
So typically it's a number of lymph nodes involved.
So a few lymph nodes involved would be a stage 2. A lot of lymph nodes involved makes it a stage 3, but it's still limited to the breast and the lymph nodes.
So it's within it's within a surgical and a radiation field, meaning your surgeon can go in, remove the tumor, remove the lymph nodes, and then you'll have radiation. Obviously, don't talk about anybody, but you'll have radiation then to that whole area. So
Does the size of the tumor and if it's affect the nipple makes it stage 3 also?
So the size of the tumor, so if there's no lymph nodes involved, the size of the tumor can take you from a stage 1 to a stage 2, but the stage 3 component comes in when there's lymph nodes involved. Now, there are some people that have what's called inflammatory breast cancer, which is a different entity in of itself. Is those patients will have that really red, hot, firm breast, which looks like they have like an infection or a cellulitis, we'll sometimes say. And those patients are usually more advanced, locally advanced, but more advanced than your typical.
And they almost have
always have nodes
involved
matted.
too.
I mean, it's a very,
Okay.
Yeah.
You mentioned a very young cancer patient at 21. Is there a trend to get screenings to be for younger women? It used to be 50, now it's 45.
So if those women have one of the genetic markers, so a couple different things. If there is a strong family history, you'll usually want to start screening, 10 years prior to that youngest individual diagnosed. But if it's a strong family history and there's a BRCA gene involved, usually you're going to start screening. The problem is mammograms and dense breasts are very difficult. So when you're talking about a 25-year-old
and young women have dense breasts,
just by the nature of their,
and so the mammograms aren't very reliable.
Right.
And so you might say, well, let's start screening, but in reality, they're not very good screening tests in young women with dense breasts.
That's why for BRCA, for a patient with BRCA in their family tree, not necessarily that, they'll start getting alternating MRIs and mammograms, but they need to do the MRI with it. And you'll get that covered because you can prove, genetic inherent, you'll have a genetic link. But your average patient, unless they've got a palpable mass at the age of 20, isn't really gonna, there's not really going to be a lot of utility in getting.
Yeah, it's a good question. And we often talk about the population as average risk versus high risk. So if you're average risk, meaning you personally don't have a genetic mutation and you don't have a first degree relative with the cancer, you would fall more under the average risk. And even there, the different organizations might quibble between 40 and 50
Yes,
for
they
the
do.
first time of the mammogram, but that would be the general age. High risk individual is somebody with a family history or a personal genetic history, or maybe even a personal cancer history that's a different type of cancer. Then there it makes sense to start screening earlier.
So when you say that, so historically we used to think of young females that had Hodgkin's lymphoma, right? Because a lot of them back, 20 years ago had radiation to their chest, right? Thyroid was involved, breast tissue was involved. So in those patients, mammogram was recommended early because of prior history, and that was a big deal. We don't usually. It's changed a little bit.
Yeah,
but
40 years ago, a teenager, a teenage girl with Hodgkin's disease would have gotten radiation, and maybe 2/3 of her breast tissue would have gotten radiation just because it's in the area where you're trying to treat the lymph nodes. And we know that that radiation to young developing breasts increased the risk of developing breast cancer.
Right.
Hence, screening at an earlier age.
What about the overall incidence of breast cancers? Is it increasing, and what do you attribute that to primarily?
So 1 in 8, it's for the last, actually hasn't, 1 in 8 females will be diagnosed with breast cancer. And actually I've given the breast cancer lecture to the residents the last 4 years, and it has remained 1 in 8. So it's not necessarily, it's not changing. Detection is changing. Percentages depending on different ethnic groups. We're doing a little bit better job with providing screening mammography to African Americans, making things more readily available. Obviously, we had this thing called COVID in 2020, which really changed, I think almost was a hindrance to our women who are getting their, not only just screening mammograms, but also our breast cancer patients, who are just in surveillance. Either we're choosing not to go, things were backed up, obviously.
Or the messaging we were giving. We were saying, stay home.
Yeah.
You can skip your mammograms.
No, you
for this
can't.
year.
Right.
And then you get them out of the habit. And so now we're in a real push
We're
to
catching up.
come back and get your
Yeah.
screening. There is some statistical predictions that not just mammography, but stopping colonoscopies, that we were going to see maybe 10,000 excess cancer deaths over 5 years after COVID because we had slowed down the whole screening process.
Not so much the incidence going up because of something going on in the environment. Well, something going on in the environment, but just not the way that we would, a different player, if you will.
And just to amplify Dr. Graf's answer, I would say that what we have seen is reduction in death rate for breast cancer because of good screening and because of better treatment. But even though cancer affects everyone, it doesn't affect everyone equally. And unfortunately, those vulnerable populations, such as African American women, their cure rate is not as good as a Caucasian woman. And we don't think that it's fundamentally the biology of the cancer is different. We think that there are just barrier to getting the same level of care through all sorts of social determinants of health and implicit bias and all sorts of things that affect it. So just as we saw, a report in the early days of COVID that individual African Americans were more likely to die of COVID than a Caucasian, it just parallels what we see through many different diseases, including cancer.
Mm-hmm. Yes. And then, we obviously, in the African American females, we do tend to see more of triple negative breast cancer too. But yeah, I would say access to care. That's the big thing. Or just compliance. So,
any other questions? Here we go.
Yes, I heard a lot of good information tonight, and I was wondering if you can touch on a subject. Maybe it's a subject for another time, but I wondering if you can touch upon it. Let's say I've have a friend who is stage 4, and you did the chemo, the radiation, and hormonal therapy, And is there a decision time where it says, okay, these guys aren't working as well as we should? Is there a decision, or what is the criteria of maybe going to like a clinical trial? Do you go into that type of aspect in your?
Yes. So
Practice.
actually, if I have, this is something that I do every day. So if I have a patient that has been diagnosed with stage 4 disease, the first thing I think about is a clinical trial. We have a number of trials between Mercy and Mission, several breast cancer trials. And so the first thing I think about will be a clinical trial for stage 4 disease. And, people think sometimes of trials as, oh, I don't want to be a guinea pig. That's a misnomer with clinical trials. And lots of cases are just using the same drugs that we use in standard of care, but just in different combinations. So you're getting the same drugs you would normally get, and just maybe you're combining them. So I will always think about a clinical trial first and foremost. Now, if somebody says is stage 4, and with a stage 4 patient, we are seeing them very often. We're checking labs, doing exams, and doing imaging. So if somebody has stage 4 disease, I'm not going to just give them some pills and say, I'll see you in 6 months, right? We're going to see them very frequently, probably image them every 3 months. So at the first sign of progression, now if it's one little spot, it may call Dr. Deming and say, hey, can we just zap it with some radiation? Because not everything's a treatment failure if it's just one area, or if it's just maybe more enhanced than it had been 3 months ago. But if there are signs of progression, I will bring up the scan. I'll talk to the patient. I'll consider a clinical trial, because some trials require you to have, not responded to X, Y, and Z, and then you're eligible. So I will always go down that avenue. And if there's not a trial, then I will have a discussion with them about the next line of therapy. Fortunately, for stage 4 hormone positive breast cancer, there's several next lines of therapy that still don't include chemo. It's different in triple negative breast cancer, whereas typically it's, it would likely be an immunotherapy or possibly chemo, but those are just, again, we're talking about different types of breast cancer. But yeah, I think clinical trials are very, very important. I am a big proponent of them because, they're great and they help people out.
Yeah, great question.
Mm-hmm.
Well, thank you, Dr. Tara Graff,
Welcome.
medical oncologist, Mission Cancer and Blood. Thanks for working your way back from Centerville, where you had a busy day seeing 35 patients. And thanks for what you do every day, day in and out, for our patients, and also how you advocate for in the community and increase awareness for breast cancer screening, detection, and treatment.
Thank you very much. It was an honor to be here.
Thanks, everybody. If you know someone who would benefit by watching this, it will be available on demand tomorrow at the Above and Beyond Cancer YouTube channel and the Mercy One Cancer website. And I hope you will join us again next week for our cancer education series. Thanks, everyone.